Well, good afternoon, everybody. Welcome to this HIC Electronic Patient Record Network webinar. I'm Hadley Stoller. I'm the Chief Executive of HIC, Healthcare Innovation Consortium. And I'm really thrilled to be joined today by our colleagues and friends and EPR network members from Ready Computing, James Gallagher, who's the Chief Operating Officer, and Phil Colborne, who's the Business Development Manager for EMEA at Ready Computing. So it's great to have you all today, and thank you so much for joining us. So if we just go to the next slide, thanks, Colleen. Just a little bit of housekeeping and just a few words from me before we get going. So we have disabled your video and audio, although there is the chat functionality, which I know Colleen and the team from HIC will be posting some questions. Please do put your name and where you're from when you ask a question, and we will be monitoring that throughout the session. So we will try and get to comments and questions where we can. We are recording the session today, and within the next day or so, you should receive that recording from us, and we'll also share the slides via email as well. Thank you. So if we go to the next slide. Oh, that doesn't seem to have moved. Okay, here we go. Thank you. So just a little bit about HIC. So we're an independent consultancy. We specialise in digital health transformation. We work with healthcare organisations and suppliers and vendors across the ecosystem to deliver evidence-based, strategic, sustainable digital solutions to improve care. And some of the organisations we worked with are on the bottom there. And some of the key activities that we engage clients with are kind of readiness and maturity assessments, procurement guidance, options appraisals and business cases, implementation and utilisation, benefits realisation, and then kind of evaluation of services. So that's just a little bit about us, and we're obviously the curators and hosts of the UK's only EPR network and EPR summits, which we'll also talk about a little bit later on. So next slide, please, Colleen. Maybe it's just on my end. Okay, cool. Okay, thank you. So as I just referenced, we bring the EPR network and community together through that infrastructure. It's a space for healthcare leaders, suppliers, vendors to collaborate and share learnings. We are planning a number of NHS-led specialist interest groups. We launched the first one last week in the space of maternity. So if you do have an interest in maternity and you're from within the NHS, please do get in touch with us to see how you might be able to be part of that and contribute. There'll be others like pharmacy and other topics that will follow in the coming weeks and months. And as I said before, in collaboration with our partners at Convensis Group, we host a number of regional and national healthcare events, particularly focused on the EPR. So we host the EPR Summit, the annual EPR Summit, and then there's others that we run, including in Wales, Scotland, and Northern Ireland. So without further ado, that's a little bit about us. I'm going to hand over to Phil and James from Ready Computing, just to introduce themselves, and then we'll start with some questions and conversation. So thank you, and over to you guys.
Thanks, Hadley. I guess I'll start. I'm Phil Colborne. I'm based here in the UK. I work for James, who you're going to meet in a moment. And my role is I head up business development in the EMEA region, which is Europe, Middle East, and Africa. I'll hand over now to James. He's going to tell you a little bit about Ready Computing.
Hey, everybody. And at least for me, coming out of the East Coast United States, good morning. And Ready Computing is excited to work in the UK and with the NHS. And one of the things that we're kind of excited to share on this path of EPR adoption is the experience we have in America with the Department of Veterans Affairs, which is a large, federalized, nationalized health system serving a designated population. And we are largely a commercial healthcare system, so there's very few American corporations that can kind of bring the years of experience that we have doing this. And even though Ready is predominantly in the US, we do have our UK team. We have about 150 plus staff members worldwide. And I think one of the funnest things about us is that we're just a great place to work. We have a lot of quals and credentials there. I won't read those. You guys can see it on the slide, but we bring a lot of passion and energy to healthcare interoperability and to making a healthcare system that works.
Awesome, thank you. Well, we'll hear a bit more about that, I think, as we're going through, right? We've got a couple of different areas of focus for this webinar that we wanted to go through. As I said before, it's a conversation. We want to engage everyone who's on the call in that conversation. So please do put your name and where you're from and your question or comment as we're talking through. But this particular focus of this first discussion point that we want to have is around system integration and the success of that, and how essential that is really for EPR implementation. So, Phil, James, obviously there's over 2 years over 2 decades, more than 2 years of experience in healthcare technology and IT. So from your perspectives, why do so many EPR deployments fall short of expectations without proper systems integration? And are there any stories that you could illustrate the consequences, when that happens?
Yeah, sure. Look, I think first of all, we should recognise the success of the EPR program, right? We've now got a situation where over 90% of trusts have now deployed EPRs in the UK. In fact, I saw some figures, I think you illustrated them recently, Hadley, with up to 96% of trusts now have an EPR deployed. So that in itself is an achievement, and it is a success. However, I think the stats hide some of the realities of what happens on the ground. You've got a situation where only 30% of trusts are using advanced functions, things like e-prescribing. But the real elephant in the room is interoperability and the capability to access and share data. Over 1/3 of trusts report they can't electronically access data from external providers. So interoperability between GPs, mental health services, social care remains a major challenge. And you've still got patient data silos. So it is great that the NHS has successfully purchased and installed EPRs. And I think the building blocks are in place. But the bigger question is really, is interoperability there? And I feel interoperability is a work in progress as it stands today.
No, thank you. And James, anything that you want to add to that, just before I come in with a quick comment?
Well, I would add that this idea that we purchase systems, we've installed them, and nobody's using them, right? It's because we've all been there when companies buy a technology solution, they get excited tech people to come in and deliver it, and then it's all tech, and we've totally forgotten the people involved.
Yeah.
As a matter of fact, they end up hating the system they bought, and they don't want to adopt it, and they don't want to use it, right? The most neglected part of technology rollouts is people.
Yeah, 100%. And actually, obviously, this is, I think, our 4th or 5th webinar now, and we've heard similar stories from some of the clinicians and others that have joined, other network members in saying exactly that. It's that change management, it's that people and relationship piece, isn't it? That's so important when you're bringing in such a big and transformational technology. So having moved from kind of upgrading communication infrastructure into healthcare, what integration challenges, feel universal across industries, and what surprised you most about health IT, James? Because I know you've had a really kind of varied background, and so it'd be interesting to see those parallels, but also kind of what did surprise you, because it may not surprise us, but we'll see when you enlighten us.
Well, kind of just to tie it back into my first comment there, that forgotten element is people. Let's think about the user experience. In healthcare, we have 2 user experiences. We have the people who deliver the care, the nurses, the physicians, clinicians, staff, and then we have all of us that are receiving care. And if we think about our experience as people in digitized healthcare systems, compare it to banking, right? Nobody actually goes into a brick and mortar bank anymore and goes up to a teller to physically transact the experience. Banking has made itself so convenient and mobile. We can get mortgages on our phones. We can check balances. We can purchase groceries at a store by just tapping the phone. There's so much that we have. It's such a convenient experience to enjoy. And healthcare simply hasn't gotten there, right? Now, banking has simplified data in the sense that it's all financial, and healthcare is very different. As someone's going to get a lab to check for diabetes, or someone's going to get a lab to check for cancer results, those are 2 very different value sets. which are very different for prescriptions, which are very different from allergies. You have x-rays, which are image files, which are different from MRIs, which are a different image file, which is different from an EKG, which is an audio file. So healthcare just has such a diverse range of data, but we still get sucked into chasing technology and we forget the human experience we're there to deliver, right? A truly integrated system is one where all of the data flows and all of the staff want to use it. They feel like it makes their life better, and patients are getting a better healthcare experience through that.
100%. And I did ask you if you'd be happy for me to share this example, James, with the group, but that's at all levels, isn't it? And, you know, we often talk about the complexity of these things, which is obviously true, but as a really simple example, in the preparation and lead up for this webinar, where we did a bit of a dry run with you guys and tried to, you know, make sure that everything was working ahead of today, we found that Teams wouldn't work for you in the same way it worked for us. So even at that very, very micro level, you know, sometimes
Yes.
the technology that we think is there and is working just sometimes doesn't work, right? So it's in all corners of our life, really, and that's without a big complex system like an EPR.
Exactly.
So with that said, what would you say, you know, both of you, but maybe come to you first, James, you know, what's the most overlooked system or kind of data source that makes or breaks EPR integration? If you could kind of, you know, identify one or two kind of key things.
That is an excellent question, and it's one I love, because the most overlooked thing in the EPR adoption and deployment is actually all of your distant ends. I like to joke that I'm an old Army guy. I was a radio man in the Army, and everything was always the distant end's fault, right? It was never a fault on our side. But it actually is true here in the commercial world, especially in healthcare. You buy a new system, you deploy a new EPR, and did you look at A, all of the systems your patients come from, and B, all of the places your patients go? And what systems do they have, and what capabilities do they have, right? Are you a Microsoft Teams shop and they're a Google shop, and now you can't get into each other's meetings? You buy the system, it says it's interoperable, it says it's going to connect, but no EPR stands alone. You've got x-ray systems, lab systems, prescribing systems, appointment and scheduling system, and on and on and on. So not only do you need to look at your facility and your system and what is your EPR going to do for you, you need to look at all the places your people come from and go to, find those distant ends, analyze their capabilities, and make sure you get a system that can become an end-to-end solution for you.
And just to add to that, and then I'll maybe come to Phil, obviously the other complexity, I think, from what you're describing, is that obviously there's multiple different systems holding lots of different data in lots of different places, which obviously the EPR is aiming to bring together. But of course, things don't sit still. The EPR itself develops and requirements are changing, but then equally, those source systems are changing. Sometimes they physically change to new providers, but often they will have roadmaps and features and integrations. So it becomes a big kind of ball of wire, doesn't it, that has to constantly be untangled or proactively working towards it not becoming tangled, right?
Yep.
But Phil, I don't know if you want to come in, if there's anything that stands out for you in terms of what's overlooked, you know, what data source or key thing is overlooked when EPR integration is kind of taking place.
Yeah, I think that's a great question, because if you bring it back to the UK, I think for me, one of the kind of gaps is around FHIR, and is FHIR being utilized effectively? As you probably know, FHIR is the global industry standard for specification for exchanging healthcare information, and the NHS has recognized FHIR as the standard for its national interoperability strategy. So the adoption inside the NHS is actually pretty high. You've got like 75% of the NHS actually implementing FHIR today, which is great. However, when you then start looking in the reality of the situation, over 2/3 of trusts already state that their new EPRs that they've actually procured can't talk to each other. So you've got the EPR, but the EPR can't talk to the EPR, right? So whilst FHIR is a mandated technology, it is being heavily used in the NHS, which is great. But it's a nuanced picture in terms of, you know, successful implementation. And I think what we haven't really seen yet is the adoption of technology delivering outcome. And that for me is a big worry in the NHS, because, I'm one of the old school guys that worked in the national program before, right? I saw the investments in technology, but I didn't see the outcome. And it scares me today that we know the answer to the question, and we even know the right question to ask. The bigger issue for me is, can we deliver upon that? And that comes back down to this simple question. The tech exists, it's there, we can do it. What we have to do is to prioritize it. And I'm not clear, and I'm not comfortable really that prioritization exists today inside the NHS.
Yeah, no, interesting. No, it's interesting. Just because it popped up as you were finishing up there. So Lee Rickles from Humbo, who needs no introduction, and good to have you here with us, Lee. But it says it's more about fire. It's the resources and the APIs. Most EPR vendors don't comply to the contracted requirements. Hopefully, the Data Use and Access Act and regulation enforcement to be issued standard will help. Purely just as an FYI, and I'm sure if we've got a link or whatever, we can recirculate it to people today. But not that long ago, we did a webinar with Hill Dickinson, who are also EPR network members, and we spoke about this act and the legalities around making, contractual mechanisms, putting those in place to make sure that those standards are met, and that is something that's kind of given a bit more robustness and rigor to. So it's an interesting point, Lee, and encourage you to look at that. But yeah, I think we all agree with that, don't we, really?
That's true. And Lee's picked up on a great point there. And, I have to be careful because I can't go chucking people under a bus, but he's hit it on the head, right? The gaps aren't necessarily from the NHS standpoint. Sometimes the gaps are from the technology provider standpoint.
Yeah, 100%. Again, I won't name drop, but I can see that there are other EPR network vendors on the call. And there are obviously lots of NHS folks too. So if this is resonating, and if you want to kind of comment in the chat, please do, and we'll come back to that. So that was the first area we wanted to focus on, and that leads us really nicely into the second kind of part that I wanted to discuss with you today, which was around the unlocking the data silos in terms of interoperability. So James, obviously you're in the US and you have a big US presence. What can the NHS and private providers learn from Ready Computing's work, particularly with the US VA, Veterinary Affairs, and maybe you could explain the work that you're doing there as well for context.
Absolutely. So to give a bit of context about the U.S. Department of Veterans Affairs, right? We're supporting just north of 15 million veterans. It's 172 hospitals worldwide, right? So we got veterans from Guam and the Philippines all the way to Landstuhl, Germany. Around the world, we have veterans, over 2,000 clinics, and it's 132 unique EMR, EPR instances that we had to wire up and connect. And then we had to create a golden record, a truly federated and longitudinal record of the veterans' experience and health, and put that up in the cloud and keep it secure. And in creating this nationalized health system that supports this giant population, the lessons learned are many, but I'll run through a sort of a few highlights. First, just the value of having a single golden record. So, in America, we'll have veterans who spend their summers in Minnesota, and then as soon as it gets cold, they're moving to Phoenix, Arizona, or going down to Florida. So half the year, they're getting their health care from one doctor. The other half of the year, they're getting it from a different doctor. So you've got different prescribers, you've got different facilities, and each one only has half a story. So integrating the health system, creating the full picture, means wherever that particular veteran would go, their provider can see their full medical record, and they can see perhaps any changes to the treatment plans or care plans that the physician in their winter or summer home may have had for them, right? Additionally, and this kind of ties back to my theme around people, different hospitals specialize in different case and care flows, right? So you might have one hospital that just has an exceptional cancer care unit, and then you have another facility that has an excellent mental health unit. They deal with Parkinson's or dementia or things going on, right? So when you want to send a person to a facility that has a specialty, like this is where you're going to go to get a hip replacement. They have the best rehab that you're going to get and the best surgical center that you're going to get. You're in a way saying that hospital has different workflows and different procedures than my hospital does. And one of the biggest challenges in integrating all of those hospitals was creating a universal data understanding, creating that longitudinal record, but doing it in a way that broke the data free so it could move out of one hospital system into the other hospital's EPR system and be usable when it got there in the way that they do their work. As the NHS looks to move towards a single care record, one of the dangers is that data gets so tied to the screen, the technology gets so constricted, it forces a single care management process, right? We don't want that. We want the hospitals to maintain and the trusts to maintain their identities, maintain what they can do. The data needs to move, but each hospital needs to be able to support its own workflow because that's what their staff are trained in. That's how they operate, right? So you're super disruptive if you lose that. And then lastly, I would just say was the value of resilience to the data. Once you break it loose, you get it into the cloud, you get it secured in a golden record. It's now facility and system independent. So this hospital's doing an upgrade. This hospital just swapped this lab system. This hospital's having a power outage. Whatever happens, the data doesn't disappear suddenly because they're gone. So you can do mobile clinics, you can do pop-up clinics, you can do care everywhere. You can have in-home care specialists going out, and the data is always available and it's always there for people who go out and provide those services. So break the data loose, I guess, is the ultimate lesson. Break the data loose, make it democratized so it can get out to every system, to every place, and let them do care the way they want to do it, where they want to do it. Now,
Yeah, no, absolutely. And you picked up on something there around, making it real, making it about that person, moving or, going between one place to another, touching different parts maybe of the ecosystem, etc. And I guess just a question there is really around, how interoperability directly impacts patient care and how does it? Because it's a big word, it's a complicated word, it has complicated meanings really, but on the ground to us as patients, to our families, etc. How does it impact patient care, and why should it be prioritized as part of any EPR kind of strategy? And when I say strategy, that's for the 4% of trusts across the UK that's still procuring an EPR, but of the 96% that do have an EPR, but it may not be utilised and optimised, to its fullest capacity. So, what are your views on that?
I think we've all had that experience where you're with your GP, they run a set of tests, they come back with some results and say, I need to send you to a specialist, cardiologist, gastroenterologist, whoever it might be. You finally get that referral. You wait X many weeks or months till your appointment comes up. You go to your new specialist and they say, oh, we didn't get a copy of those tests. We didn't get a copy of those labs. Let me order you some new ones. You rerun all of that testing again, have to make another appointment and wait again. All the results got to come back. You're duplicating care. You're delaying delivery of treatment, right? You're just creating costs that everybody has to bear in one way or another. And you're not getting the person back to healthy again. All of those experiences could be removed with a properly integrated health system with a universal record. Why can't your specialist see the exact lab your GP ordered? Why can't they see the exact image that was looked at when someone said, I think we might have an early detection of cancer? Because those times wasted hurt people.
Yeah. There's an interesting comment in the chat actually that the reality that Gary says is the reality is that nobody under 40 on this call will ever see a national shared patient record. Maybe that's something to come in quite nicely to you, Phil. Maybe if you want to respond to that, but also kind of in your UK experience. So obviously that international experience is, I can see those parallels, and it's super interesting to hear that. But from your experience here in the UK, how do clinicians react when data finally does start flowing across this, silos? And are there any stories that stand out? Because we're talking a little bit pessimistically that it doesn't quite work, but we know that it does work and that it can work, and when it's done right and well, it has great impact on patient care. But are there any stories that stand out in that respect?
Yeah, I mean, interestingly, Gary probably knows this because my background's imaging, right? I worked in imaging in the last national program, and the only really big success of the national program was the rollout of PACS, right? Imaging nationally, it still had huge gaps. but principally every trust got a PAX, and every trust went digital. So the story I'd share with everybody is I work for a company that provided a global cloud-based imaging platform, which was used extensively by independent reporting companies. So companies that provided reporting services on your studies by private radiologists predominantly. And I had responsibility for taking a group of these guys from Portugal to a conference in America, RSNA, which is the kind of the global radiology congress based out of Chicago. And my responsibility was to kind of look after these guys and make sure that got to where they needed to be. First day of the conference, I turn up at the hotel, and there's a bunch of them sat in the foyer of the hotel, and they're all sat around a laptop. So I go over and I'm like, what's happening, guys? And they go, oh, we've been asked to participate in an MDT, a multidisciplinary team meeting, regards a patient that's had a stroke. And one of the clinicians is a specialist in stroke, and they're asking for his input. So these guys are sat around a laptop, and they're looking at a bunch of studies that were shared from Spain. So a hospital in Spain has uploaded the images to our cloud, and these doctors are looking at these images, but they've also kicked off an MDT, and they're actively looking at the radiology reports, and they're giving feedback and sharing information. So if you think about it, this is like a bunch of guys from Portugal looking at images generated in Spain from a foyer in America, right? And that, for me, really highlights, the kind of what can be achieved by, applying standards. If you apply standards, and imaging is really good at this. This is the one thing that imaging has really, really delivered into the digital healthcare environment. The application of standards means you can do stuff like that. You can have a doctor who is from one country integrating to a platform from another country in a completely different environment, and still being able to do the job that he's paid to do. And that, for me, really highlights where the gaps are in the EPR space. And if we could achieve the same things in the EPR world, then that's that kind of that golden outcome that we're looking for.
Yeah, and I guess in your experience, it's very positively received, isn't it? Clinicians and others, because it's not just clinicians obviously using and benefiting from the EPR. That's kind of nirvana, isn't it? Really, when you get to that point.
And people forget about the kind of soft benefits that these things generate as well. The ability, for example, doctors to become so much more efficient, right? A doctor that can work anywhere at any time suddenly becomes a much more efficient resource, right? So not all of these, I mean, you're never going to fix all the backlogs, but a lot of the backlogs that exist within the NHS could be fixed purely by just making the doctors more efficient. And this, this drive towards AI and all the rest of it is a great thing, but actually start addressing the underlying issues, which is just getting doctors more efficient and allowing them to be able to do their jobs better.
Yeah, 100%. I was going to ask you a bit later on how you kind of bring clinicians in early into this conversation, but maybe the answer is in the question, which is bring them into the conversation early, and make sure that you're designing something that's not just a technical solution, but one that really, has included and involved the ecosystem of users within that organization. So I guess just a quick fire question to both of you. What would you say is the single most practical thing that boards, across the NHS, within acute trusts, ICSs, etc., and we've got a mixture of those on the call today. What can they do to make interoperability a kind of non-negotiable part of the procurement process and part of the governance of not just procuring these solutions, but then ultimately embedding and optimizing them?
That is another question I'd love to jump in and answer. The comment of nobody under 40 is going to see that. I laugh a little bit. When we did it for the VA, we were the VA's third attempt to do it. So they had a procurement that they ran back. It was 2011. That was the attempt to create a national record. Spent a lot of money, spent a lot of years. It didn't go the way that they wanted it to go. So in 2015, there was another procurement that brought in another vendor. They spent a lot of money. Now they had lessons learned from the first time. So they got something working. But by 2017, they're like, this isn't really what we wanted to do. So they did a third procurement, got it out. It was released ready, got that one in 2019. And so I'm going to give a lot of credit to the VA as a procuring org, that they really listened to what worked or didn't work with the first few attempts. They released a procurement in 2019 for the third one. And we're a small company at only 150 employees. It's really hard for us to win federalized work when we're up against giant corporations. You guys all know the usual suspects there. But they chose us and we built it. We started work July 1st, 2019. We went live April 16th of 2020. We did it in about 9.5 months. We brought the whole system live and deployed all of the hospitals, right? But there was one effort around procurement and there was another effort around the build. I led the build. I had hair when I started that build. It was a stressful run to get it done in 9 months. And so the question is, what can procuring trusts do to make sure they actually get the system they want, right? Is to, I would say, don't focus on the systems at all. Focus on the solutions that you need, right? So when I mentioned where do your patients come from, where do they go, what are your referral paths, look at your entire connected system of partners, all the specialty practices, all the trusts, care facilities, nursing homes, everything that connects into what you have. Take a look at your total package and take a look at all the points of contact between your system and those points of contacts and say, I need solutions, which might mean multiple systems. Right? You might need to get a scheduling system to go with your EPR system or to go whatever, and make sure you have an integrator as part of it. And this is going to be a bit harsh, that isn't the EPR vendor themselves, right? There's a comment that was made earlier in the chat about the EPR vendors kind of not delivering necessarily what they say they'll do. One of the things I love about the EPR network that we're part of, that's being led here by the Health and Care Innovation Consortium, is that we're a collaboration of integrators like Ready Computing and EPR vendors that are inside of this. We're actually committing to this sort of thing together, right? You need the EPR vendor to be at the table, but you also need to bring an integrator to the table who's going to handle everything that's outside of that EPR, all those connecting endpoints that need to come in. Somebody needs to be the voice of those endpoints and what those systems capabilities are and how to wire them up properly to the EPR vendor.
Yeah, no, awesome. Thanks for the shout out there as well, James. Obviously, that's part of what we see as the role of the EPR network, to be that organisation in the middle that can be the link between those NHS organisations and suppliers. So obviously, if there's anyone from the NHS on the calls that would like to engage with the network or our summits, please do so. But I think that's a really important point, and I like what you said there, James, about really it's not about the technology. Just go back to the basics and try to understand what problem are we trying to solve, what are those flows, what would a good system look like for us. And I think that's how that's how boards can make these kind of procurements and rollouts really effective, isn't it? Because it's based on what the needs of the system are, as opposed to what we think they are.
Right, exactly. And if I was to really hyper summarize those 3 attempts by the VA, the first attempt didn't work. The second attempt did work, but it wasn't what the users wanted. It wasn't what the healthcare staff needed. It was the third attempt. It was like, okay, now it works, and it's the one people want to use, right? And getting that voice of the user in there early definitely helps.
100%. Phil, do you want to come in and give your kind of, most practical points?
I find that a really interesting question. And as far as, again, we've kind of been around this route as a country before. And I think for me, clearly mandating as a non-negotiable element of any contract that integration has to be part of it. But that's great, right? That's 50% of the problem. You've effectively said, but so what if you don't deliver? It doesn't make any difference, right? Nobody feels any pain other than the customer if you don't deliver from a supplier standpoint. And we saw this extensively last time we went around this route. So I would build in interoperability into the commercial element of any contract. As salespeople, we always say compensation drives behavior, right? If you pay the guy, he'll do the job, and it's simple. Therefore, if you don't pay the guy, then he's going to feel the pain too, right? So my position on this would be actually build it in commercially, right? If you within the contract, it says you will connect A to B. If you don't make A to B talk to each other, I don't pay you.
Mm.
And it's as simple as that, right? You wouldn't take your car to a garage and say, the engine's broken, please fix it, and then have the car come away with the same broken engine, right? And that's pretty much what I've seen happen so often in the NHS. The NHS pays the bill even when the service isn't delivered. You've got to make the contract, going back to the Hill Dickinson piece and all the rest of it, make the contract as tight as it can be and make it simple. Here is the requirement. We want A to talk to B. If A doesn't talk to B, you don't get paid. Simple.
Yeah. No, lots of parallels there, as I said before, between what you're saying here, Phil, and that Hill Dickinson webinar. So I think the team have put it in the chat, and I'd encourage people to look at that. So no, that's been super interesting. So I just want to talk a little. So obviously we've spoken about what to avoid, what those lessons are, how to kind of best shape what good looks like from an integration and interop perspective. But now just pick up a little bit, I guess, on kind of the value in terms of benefits that are realized post go live, and analytics, AI, pathway redesign, that value beyond go live, and that long-term kind of value and risk management, really. So what would you say are the next steps for healthcare organizations to do to kind of what steps should they take really to future-proof their EPR investments through integration and interop? Because I suspect that the majority of the NHS folks on the call today probably have an EPR. 4% of the country is not very many trusts. So on the assumption that the majority of people have an EPR, what can they do to future-proof those investments? Because as we said before, the EPR doesn't sit still, and all of the systems around it. So, what would you recommend? Maybe I'll come to you first, Phil, in that respect.
Well, again, for me, if you're talking about protecting an investment, and again, coming back to an analogy, you can keep a good car on the road for an awful long time as long as you actually look after it and you provide it with with the right elements that allow it to to continue to run. And I think that there are multiple pieces of technology when aligned to the EPR can just continue to grow the value of that EPR. A good example is like the shared care record model, right? Shared care record is a technology that exists out there. There is the capacity and capability and technology available, and vendors like ourselves that can go deliver the shared care record. That means the EPR doesn't need to keep developing. You don't need to keep spending the tens of millions of pounds that an EPR costs to be able to bring it up to its modern and latest version. If you apply a shared care record model around an EPR, you suddenly get 90% of the benefit without all of the cost. So I mean, that's a very simplistic response, but the reality is that if the market comes out to organizations like ourselves, and there's multiple companies out there that do this, right, and actually sit down and have a grown-up conversation and say, how do we leverage our EPR, right? It's in place. We've got it, right? Yeah. The engine is there. How do we leverage it? Come talk to us and we can build a message or build a model for you that actually elongates that investment, gives you that capacity to be able to get true return on investment for the EPR.
Yeah, no, great. And we've alluded to shared care record, and obviously single patient record as well came up in the chat. So that there's lots of different kind of what's the word, periphery systems as well. But I guess, James, what would you say in terms of future proofing, the EPR from a trust perspective?
Absolutely look for where you can use shared infrastructure components. Right. So I will give an example, user logons, user credentials. If you have an EPR and then you have X many connected systems that are with it, and then they all decide that they're going to share the credential from your EPR, that sounds like a really good idea because you don't want your staff to have to memorize 100 passwords, go to 100 places to log in. But now what happens is all of those surrounding applications that are sharing their credential from your EPR, if your EPR upgrades or moves, all the surrounding applications broke. Yeah. But if you use, for example, a single sign-on service or some other type of authentication service that's independent, and the EPR and the applications all use that shared infrastructure source, then the EPR can go through an upgrade or you can swap it out and you're not suddenly breaking every application that came in.
Mm.
Likewise, when you think about APIs, Phil mentioned FHIR earlier. If you can use standards for your interoperability, then when an application needs to change or your EPR needs to change, whatever new system comes in can immediately use that existing data API. But if someone says, oh, we have these custom bespoke APIs that will run right into your stuff, then as soon as you upgrade or touch your EPR, you're breaking that surrounding application. And
Yeah.
sometimes what happens is so much stuff bolts onto the EPR with custom integrations, no shared infrastructure, everything's bespoke, that when it comes time for you to change your EPR, the cost just goes through the roof because you also have to now go back and fix things in other systems. So I would say absolutely hit shared infrastructure. Sorry.
Yeah, no, I was just going to say, you've also picked up on another really interesting point, and again, a webinar that we ran with another network member, SI Squared, which again, maybe the team could put in the chat, the link to their webinar, where we absolutely spoke about, for the hour, the important role of standards. And I think the two key things so far that have come out for me for this conversation, one is, contractually make these things, fixed so that they are delivered, but also do it in a standardized way that makes future iterations and versions and innovation that comes from that EPR system, put those standards in place to make it easier. It's not just about designing the house on the plan, is it? You've got to build the house and you've got to live in the house, and it's the same principle, isn't it? Once you've got that EPR, you've got it for 10 years minimum. So make sure that it is, that the foundations are there. Otherwise, just like a pack of cards, the whole lot will fall down at a later date. So it's really interesting, and I might come back to you, James, really, just for a quick kind of positive and maybe not so positive example to share. But from your work with the VA, what's one lesson that you think translates directly to the NHS, and maybe one that doesn't, that you might be able to share with us?
Absolutely. And I'll weave an answer in. Mark Mulholland in chat there mentioned about neighborhoods and sort of doing things within localities. The VA has regional collections of hospitals that are called VISNs, and they use those for all kinds of stuff like procurement. So if you're ordering tongue depressors and splints and your facilities are all in the American Southwest and New Mexico and Arizona, you don't use the same suppliers as the facility hospitals up in New England and Massachusetts and Maine and Vermont, right? So we built regional routers for HL7 messages, for example, and a national backbone. So if somebody does need to send an HL message from California to New York, they can across the VA network. But more than likely, they're probably referring from Los Angeles to Sacramento or something regional that's happening there. And those messages only go through the regional exchanges. So you kind of do need to address both the national and regional and local. And you need a strategy for your interoperability that allows for that, because a lot of hospitals don't need to see the traffic of every other hospital. So a lesson learned that we can take from the VA and apply to the NHS is kind of where you were going there, Mark, which is having a strategy for layering all that interconnectivity, because not everybody needs every connection every time at every moment, right?
That's right. Yeah.
One lesson that probably wouldn't apply to the NHS is don't swap your EPR in the middle of connecting all of your EPRs. With a little bit of humor, when we did the VA's sort of build, they had just announced they were going to swap to the Oracle Cerner EPR and go through this big change out. So in the midst of wiring all of the facilities and bringing all the connectivity along the line, we had to have a whole designated sub-task force to bringing up the Oracle Cerner EMR and bringing it into the network, while a hospital that was on one EPR suddenly dropped it and swapped to another. That introduced a whole layer of complexity. So please, as you're building it out, connect up the core systems you're doing, and don't swap horses in the middle of the race. Would kind of be a fun lesson that hopefully won't apply to all of you.
No, I like that. I like that a lot. No, it's really good. And thanks for picking up on Mark's point in the chat. Maybe we'll come back to that also later. And I guess, maybe to both of you, bring you in, Phil, give James a second to grab a drink. But, how do you adapt, global best practices, I guess, which is ultimately what we're talking about here, without copying them wholesale? What's the art of that localizing and how we, learn from what really works well within a locality, within an organization?
Do you know what? I think James is probably a better place to answer that question.
Okay.
The reason being, and again,
Copy.
I'm happy to give input, but I'd rather have James give input from a real world scenario. So
Okay, no problem. Yeah. No rest for you, James. Sorry.
Yeah, don't rest. That's fine. So the question was, how do I take like a global best practice and adapt that to a localized practice?
Without wholesale copying it, because there might be people on the call thinking, well, that sounds great, but actually that probably, you know, we're unique, we're special, we're different here. How do we take that and kind of mold it and shape it to you know, to our organization?
It's the difference between data and people. If I kind of go back to what I said at the beginning of the call, your data practices should be global, your people practices should be local, right? And people shouldn't be slave to the data should be slave to supporting the people, right? So you can use an interoperability standard or a messaging standard that says, here's the 20 data fields that we must exchange in order to do a heart surgery. That should be universal. Every trust, every hospital should know those 20 fields need to be exchanged and agree on how they do that. But how a particular facility approaches doing that surgery, it should definitely stay local. So realize your people and your workflows are yours. The data is what you make global.
Yeah, no, 100%. And what do you think, kind of in terms of governance then? Because there's a lot there, isn't there? We've spoken about standards, legalities, pathways, solutions, different national infrastructures, learning from, you know, some of the pieces of the jigsaw that you've described. What, you know, what are the overlooked governance lessons that you know, the UK Trust could perhaps apply to kind of not let things slip through the net in that respect?
I would say make your governance bi-directional. And here's what I mean by that. In interoperability, historically, the burden is always on the receiver. So you say, oh, I'm going to connect to this other institution and they'll throw data at you. And now it's your job to clean that data up, right? So as a person connecting, it's always the receiver that always has to clean the data as it goes. Probably the hidden lesson in governance is make the people onboarding and send data, make them be more mature, make them conform to the national standards that you want before they put their data into the system. Don't settle for letting the burden of cleanup always being on the receiver, because that makes the integration experience really painful for each new person that joins in. And that's where all that bespoke stuff comes, because if one person's pumping dirty data into your system and 10 people are receiving it, all 10 of them are going to clean that data differently.
Yeah.
Right.
So there's something about baselining it, isn't there? Making sure that, you know, like the saying goes, right, rubbish in, rubbish out. So making sure that what goes in also conforms to that standard. It's not just about having a system that is gold plated, but everything else has to be at least silver plated before it gets in there. Otherwise, you know, the whole thing falls down, doesn't it?
I always joke about. Go ahead.
Yeah, no, go on, James.
I was gonna say, I always joke about amusement parks that have the little sign that says you must be this tall to ride, and the kids always go up and stand beside it, right?
Yeah.
Make your vendors actually be tall enough to get on the ride. Make the senders carry some burden in your system.
I like that a lot.
Hadley, one of the things we learned, and again, I know I go back to imaging a lot, but one of the things we learned in imaging was this concept of was disconnecting the data from the application. Because once the data and the application is separated as much as possible, it means that one, you can replace the application without a ton of pain, which is quite a a valuable element. The second piece is you can work on the data. Right? If it's locked up in a silo, you can do nothing with it. Whereas if it's separated and put into a different archive system that you own and you manage, you can go work on that data. So if you do need to clean it up, you can go clean it up. You can go do that ugly piece of work that you perhaps couldn't do inside somebody else's system without either their support or additional cost. So there's a lot of value in actually doing that separation piece.
Yeah, no, awesome. No, it's great. And I love that theme park analogy though, James, as well. I think that is super, isn't it? It's just make sure that you're tall enough to be on the ride. I love it.
That's right. Vendors, look, I'm a vendor too. Vendors make promises, and a lot of you guys know that. There's been comments. Make sure they're really tall enough to get on the ride.
Yeah, no, love it. I can see a LinkedIn post with a. Anyway, let's not get carried away. So that's kind of come to the end of the formal questions. I suppose one final question really is just, you know, if you wanted people on the call, you know, today to take one thing away, you know, what would you want them to take away from the discussion? You know, what question or thought would you want them to leave with after listening to, you know, everything that we've gone through today?
Well, I would say don't be intimidated. I know we talk a lot about lessons learned, and sometimes a problem looks really hard and it's never going to get there. No one over a certain age is ever going to see it in this lifetime. Don't let that stop you. I will just say it was the VA's third attempt when they hired us to come in there, but we got it live in 9 months. This actually is possible to do, and it does happen, and it does work and make a difference, right?
Yeah.
So be brave.
Awesome. From a UK specific standpoint, I'd say come talk to people like us, right? I see too often that, you know, the big boys out there charge a ton of money and time to come and tell you pretty much what you know already. And I think actually sitting down with a smaller organization that actually, you know, is at the coalface, has felt the pain, understands exactly what the customer needs, is not only a much more sensible approach, but actually it's a cheaper approach generally, because you're not going to be paying the kind of crazy money that you would to a huge consultancy group to come tell you something that really you probably know already.
Yeah. Awesome. Okay. Well, there's time for questions. I'm just going to run through a couple of slides before that, but obviously just a premature thank you to you both for that insight. Just while I'm kind of updating on a few other points, please do put some questions in the chat and we'll come back to it. So the conversation doesn't stop today. That's the whole premise really of the summits that we run with our partners Convenzers Group. We continue the conversation in every corner of the UK. I'm thrilled to see colleagues from Wales, in fact, on the call today. So good to see you, even though I can't see you, but you know what I mean. And the HIC team, with a lot of the majority of the EPR network membership, will be in Wales, in Cardiff, on the 18th of November. Please do take a screenshot of the QR code. Come and register. Come and sign up. Come and listen to all the various speakers from within the NHS, but also from within Wales too that we've got on that day. It'd be really great to have you join us, and if you're a supplier and you're interested in coming along, feel free to reach out to us on that front. So that's Wales next month. And then our kind of annual EPR summit too, which I think the date has actually changed now to March. So apologies for the typo, but if you take a picture of the, it's the 3rd of March. Yeah, thanks, Colleen. If you take a picture of the QR code there, that would be great to have you there. That one's in Birmingham on 3rd of March, so it'd be good to see you there. I think that was that everything, Colleen. I think from our side, I'm not sure if there's one more slide. If not, we will, just come, obviously connect with us. There's our email address and contact details. I think some LinkedIn connections might be in the chat as well. So I guess just in the last few minutes, I'm happy to open up to any questions or comments that anyone may have for us. Feel free to, thank you for that, Rhiannon. Thank you. Feel free to kind of ask a question and we'll happily take it. But I suppose just while we're waiting, maybe to both of you, you know, just picking up on that kind of point of future proofing and how EPRs, you know, tend to evolve and the systems have to evolve around it. We often hear about pilots, of which, you know, we've got far too many in the NHS, in my opinion. We've got more than British Airways, to be honest. But in terms of these pilots and proof of concepts that take place, you know, how do you, because what you just described, James, was amazing in terms of those failures, but then turned into a great success. And I think that's okay too, right? But how do you stop, pilots, proof of concepts, demonstrating really, really good stuff? And how do you stop that momentum fizzling out? You know, you achieve something, you've tested it, you've proved it, but then kind of, you know, it doesn't carry on. The momentum stops. How do you stop that happening?
Well, there's a lot of answers to that one, but I'll give a couple. One is make sure that the pilot you're running is solving a problem that others also have. Right? So if you're running a pilot to a solution that's somewhat unique to your facility, then when it runs its course, it's kind of done. But if you have a problem and the other trust has the same problem, and another trust has the same problem, and you run a pilot that solves that problem, share that result with the other trusts that have the same problem and begin to build sort of organizational will to adopt it at a broader level, right?
Yeah.
That's sort of one thing I would definitely say. Sometimes pilots get a little bit too narrowed on solving a particular problem of a particular facility. And
Yeah.
even as you're starting your pilot, check with your peers and other trusts. Do they have the same problems? Where they like to hear about your pilot while it's happening and ongoing? Because you can start to generate collective organizational will in them early if you do.
And I think, just going back to those previous slides that I've just shown, the part of being at those EPR summits is exactly about building that community to share that learning. Obviously, you don't need to wait for a summit for that to happen, but I think that's a good platform, isn't it, to start engaging and continuing those conversations. But you're absolutely right. Let's create that environment of sharing knowledge and lessons and what's worked well and what hasn't. Phil, I don't know if you want to add anything to that.
Yeah, I think for me, you have to think about the nature of the NHS, right? It's a free at the point of delivery, a clinically delivered service. Therefore, if you don't have full clinical input, a project is never going to develop. And I've seen so many projects fail because they go to POC level, because the technical guys are behind it, they love it, everything works. But because the doctors aren't behind it, or the clinical delivery teams aren't behind it, it never gets past POC. If you don't get that clinical input, you're never going to get a POC to a point where it's accepted in the real world.
Yeah, no, absolutely. No, thank you. So kind of first and last question before we finish from probably the UK's most significant player in the standards space. From David Hancock has asked the question: could you explain how interoperability standards have been defined in the US and what can be learned by the UK?
Absolutely.
So
I'd love to jump on that one a little bit.
Yeah, go for it.
Yeah. In the US, in America, it's a bit of a hodgepodge for how it's defined, because you guys know we don't have a centralized governmental health system. So a lot of organizational bodies are formed. HL7 has a body, Fire has a body. When our payers, our insurance companies were getting in, they had the Da Vinci group that was stood up, and you get a lot of industry adoption that drives it in. And it's great in the sense that it means vendors will support it because vendors had buy-in designing it. But it's not great because of how long it sometimes takes all of us vendors to agree on something, because everybody wants to tilt the standard to favor what their product does, right? Typically, we get a new interoperability standard when our Medicare and Medicaid gets in, and they actually begin to define and push something. So for Fire, we have the US Common Data Interchange, the US CDI, right? They said this is what was going to look like in the US. And once it was regulated, it began to move. So in that sense, I would say, just to speak to national will, and that idea of put some of the burden on the sender, make sure they can actually do all they do. If the NHS published a standard that said this is what interoperability must be as a minimum, don't stop a vendor from overachieving, but you must at least jump over this bar, right? That would then push everybody forward at once to do it. And invite the vendors to collaborate with you on that. Just maybe don't do it like we do sometimes, which is all vendors in the room. Have that collaboration.
It's funny, I did notice there's a new flavor in America that suddenly appeared, TEFCA. I'd never heard of it until yesterday, and I suddenly found it through a LinkedIn prompt. And that was quite interesting. I mean, it's good to see that America's still taking that forward, if you know what I mean, still forcing vendors to work together.
Yes.
So it's clear that contractual mechanisms need to be in place, standards need to be in place, people, including the clinical folks on the ground using these EPRs, are all part of that ecosystem. And ultimately kind of bringing together the right components of what will bake the cake in the best possible way. Just a quick comment. Well, there's a few more comments. We'll have to probably respond to those offline. But just to thank you, both of you, for joining us today. Thank you to James and thank you to Phil. It's been a really insightful conversation. As I said at the beginning, we will share the slides, we will share the recording, and really thank you to all of you guys for joining us this afternoon, and have a good day. We look forward to seeing you soon.
Thanks, guys. Thanks for joining. I appreciate it.
Thanks for allowing
Thanks,
us to do
everybody.
this.
Thank you. Bye.
Take care. Thank you.